cascading, complex, and chronic type of problem amongst the society, and required the role of community at large to come together along with the primary professional stakeholders from the health sector as well as disaster management. PHEOC's concept actually has come up as a cornerstone of effective public health emergency management system. A well-functioning public health emergency operations center actually ensures timely coordination, situational awareness, and data-driven decision-making. This is going to help us essentially in mounting an efficient response and minimizing the health impacts on the masses. I'm delighted that we received a very good response from the different stakeholders, and almost more than 300 participants they registered for this particular webinar. Slowly the number is rising, and I am also thankful to the participants that they spared their valuable time to learn and to share and exchange this valuable knowledge and experiences with all of us. And I would request participants to kindly engage themselves actively in these discussions and interactions with the experts. And I would also like to inform them that there is a chat box in the webinar platform, which can also be utilized to share your ideas or information. I would feel in my duty if I don't communicate my heartfelt thanks to the distinguished speakers. Particularly, I would like to mention Dr. Sujit Singh ji, former director NCDC, who is also currently associated with the CDC US, country office India. He is well-known expert and has done a lot of contributions at the national and as well as at the global levels. And also, I would like to communicate my thanks to Dr. Saurabh Goel, Joint Director at NCDC, who would also be sharing his rich knowledge with all the participants along with our team. So I hope this dedicated webinar, lecture, presentation, along with dedicated question and answer sessions will surely help you or will benefit you in any possible manner to deal with the public health emergencies and disaster situations. Thank you once again for joining with us today, and I wish you all the best. Safe, healthy, good quality life on an equitable, justifiable, and right-based manner with good fraternity amongst all of us. Thanks to our partners and the organizing team, including Dr. Raju Thapa and also Dr. Harjit Kaur and Ms. Tenjin. And I would fail again in my duty if I don't communicate my thanks to Dr. Rajat Garg, who is actually the force behind all these organizing team to take this all on board and get it done. So thank you each and everyone, including all speakers, organizing team members, our partners, and also the participants of this program. Thank you very much and wish you all the best. Good afternoon to everyone. Thank you. Back to you, Dr. Ms. Tenjin.
Thank you, sir. Thank you, sir, for your background setting and enlightening our participants. Good afternoon, namaskar to all distinguished speakers and participants joining us from across the country. And I'm delighted to be your moderators for today's webinar under the PHEDM Connect Bridging Knowledge and Action series. And this series is an initiative, joint initiative of National Institute of Disaster Management, National Center for Disease Control, and the US Center for Disease Control and Prevention, Country Office, India. The objective of this webinar is to enhance the understanding of the structure, operational modalities, and strategic importance of public health emergency operations centers in managing health emergencies and disaster, particularly in the Indian context. Now, I would like to request all the panelists to switch on their videos for a photograph. Thank you. Before we begin, let's initiate a poll through Slido app. It is a brief participant poll to understand how many of you have attended the Public Health Emergency Disaster Management Tier 3 training program across the states, which follows Tier 2 training previously conducted in Uttarakhand and Rajasthan. You will now see a quick poll on your screen. Please respond by selecting the option that applies to your experience with the PHEDM Tier 3 training. आपके स्क्रीन पे क्वेश्चंस आएंगे स्लाइडो ऐप करके, वहां पर आपके क्वेश्चंस के अकॉर्डिंग वहां पर 4 ऑप्शंस दिए जाएंगे, उस हिसाब से आपको क्लिक करके अपना रिस्पॉन्स सेंड कर दीजिए। आपके स्क्रीन के राइट साइड पे स्लाइडो ऐप के एक ऑप्शंस आएंगे, वहां पर आपका एक क्वेश्चंस आएगा, उसके हिसाब से आपने अपना ऑप्शंस क्लिक कर करके वहां पर रिस्पॉन्ड कीजिए।
आप देखिए आपके राइट हैंड साइड पे अभी एक क्वेश्चन डाला गया है, आर यू अटेंडिंग दिस सेशन इंडिविजुअली और एज अ पार्ट ऑफ अ ग्रुप विथ मल्टीपल पार्टिसिपेंट्स यूजिंग अ सिंगल लॉगिन। तो ऑप्शन में है इंडिविजुअल और मल्टीपल, जिसमें कि हमने देखा कि 85% रिसीव्ड इंडिविजुअल के लिए और 16% मल्टीपल ज्वाइनिंग। तो आप लोगों का बहुत बहुत धन्यवाद रिस्पॉन्स करने के लिए।
Thank you for your responses, and this helps us better understanding our audience and tailor the sessions accordingly. Now we will move towards the technical session. Before we begin the technical session, I would like to share a few general instructions for all participants. First, after each presentation, there is a poll related to the topic, and after all presentation, we have a question and answer session. For this, I would like to request you to raise your question or queries in the chat box. Now we will start our technical session. The first technical session is on strengthening emergency operations planning, multi-hazard preparedness, and functional modes of Public Health Emergency Operations Center. It is now my pleasure to introduce our keynote speaker for today's session, Dr. Saurabh Goel, Joint Director, IDSP, NCDC, Ministry of Health and Family Welfare. He will speak on the strategies to strengthen emergency operations through effective planning, multi-hazard preparedness, and function models of PHEOCs. His insights will draw upon the both national and operational experience. Over to you, Dr. Saurabh, sir.
Yeah, I would like to begin with thanking all the organizers for conducting this webinar on a very important topic that pertains to the EOC and how to manage and establish the PHEOCs. Although this is a very vast topic, but in the time allotted to me of 15 to 20 minutes, I will try to give you an skeletal overview of the EOC, that is the Emergency Operations Centers, and how this is important with respect to the public health scenario in our country. I hope my presentation and screen is visible to everyone. Can anyone
Yes, sir,
confirm?
screen
Yes.
is visible.
Yeah, thank you. So basically the Emergency Operation Centers, which is acronymed as EOC, it is a very powerful concept, and you can think of it as a brain of an emergency response. So EOC is a centralized physical or virtual location where coordination, information flow and decision making happens in real time. Over the years, these EOC centers have been referred to by many names like command center, situation rooms, control room, war room, and each term reflects the intensity and urgency they embody. Now, when we bring this idea into the public health domain, we call it as a public health emergency operation centers, or acronymed as PHEOC. And PHEOC is not just a room, it is an ecosystem that brings together the surveillance, logistics, expert advice, and real-time communication under one single roof. You can imagine a scenario where an unknown disease cluster emerges in some remote village of some particular district, and what happens next? Within hours, a PHEOC is established at the state or the district level. The epidemiologists are deployed to the field. Supplies of testing kits and PPEs ensured. We start monitoring the updates from the field, and we start giving the guidance to the state or the district health departments. All these actions happen concurrently and often they under tremendous pressure. We have seen this firsthand during the COVID-19 pandemic. We have seen this during the Zika outbreaks. We have seen this during the Nipah outbreaks. So basically, with the establishment of the PHEOC, we are moving from the reactive chaos to a strategic coordination. There are three essential elements, or I can say the critical pillars of any EOC or a PHEOC. These three things are the people, systems, and stuff. So let's take them and understand them one by one. By people, we mean if we have the best infrastructure and the most advanced technology, but if we don't have the trained, ready human resource, our response will collapse. In the context of a PHEOC, the staffing refers to the trained personnel who can fill the designated positions within the incident management system, also known as the IMS structure. And these persons, they manage everything from operations and logistics to planning and communication. This staff can be grouped into two broad categories, the permanent staff and the surge staff. So the permanent staff is a full-time staff. They are the core members of the PHEOC team who understand the systems inside out. Surge staff is the group of people who can be quickly mobilized during a crisis such as a pandemic or a large-scale outbreak. The surge staff can consist of epidemiologists, microbiologists, IT analysts, and even support from administrative cadres can also be sought during the surge response. The second is the systems. By the systems, we mean the plans, procedures, and the SOPs, which are very important for making any PHEOC functional. And the third is the physical infrastructure, the facility that will serve as the EOC and the PHEOC and the necessary equipment to operate it, such as the displays, high-end computers, the GIS maps, the printers, your communication network, your data management system, and everything. So this is what converts a room with chairs and Wi-Fi into a command center for saving lives. The WHO provides a globally recognized structure for how the public health emergency operations centers should function. The emphasis here is on a goal-oriented response and a unity of effort across the various agencies involved during a PHEOC response. So PHEOC is not just a data room or a helpline center, it's the engine room that integrates all the response activities during a public health emergency, whether it is a pandemic, a chemical event or a disaster outbreak or any kind of the health emergency. So the WHO framework defines 4 key objectives under this. First one is the support public health response needs. This includes everything from logistics to the field deployments. The second is to receive, analyze, display, and monitor information. This is essentially building a real-time situational awareness using the available data. Identify, organize, deploy, and track resources, be it a human resource like the rapid response team or critical supplies like PPEs and medicines like the antivirals and antibiotics. And fourth one is to coordinate from a centralized location. So when we manage from the centralized location, this avoids the chaos of multiple agencies working in silos. So basically, by adopting this framework, we simplify the PHEOC management. While it may appear very simple on paper, but it demands preparedness, interoperability, and leadership in practice. The PHEOC facilities can be broadly divided into the 2 types. We call them as the dedicated facilities and multipurpose facilities. The dedicated facilities, basically these are the purpose built centers and they are established mostly at the national or the state level, and these are designed solely for the emergency coordination. They are the gold standards and their structure can be like studied and understood by the states and at the district and the block levels when they make their own EOCs. So basically, these dedicated PHEOC facilities are equipped with secure networks, high-speed communication, GIS dashboards, backup systems, backup power systems to ensure the uninterrupted function. Then second type is the multipurpose PHEOC facilities. These are common, especially at the district or the block level. So usually at the district or the block, the same room or a big hall or an auditorium that is used for the review meetings or training sessions can be quickly repurposed as a control room during an outbreak. While this method is cost effective, but the challenge here is the speed of transformation. And the third one is the virtual PHEOCs. It is a subtype of multipurpose PHEOC facilities. We all know about these. And this format came into prominence during the COVID-19 outbreaks with the travel restrictions and physical distancing required and shifting to the work from home type of scenario. We shifted to the Zoom-based coordination, WhatsApp emergency groups, and cloud dashboards. So all this kind of like closed meetings, the online platforms, they constitute the virtual PHEOCs platforms. We cannot rely solely on these platforms and they should not be seen as a replacement of the physical PHEOCs. This is a photograph that shows the earliest, the SHOC center in the NCDC, which was established for the first time when the COVID-19 struck in March 2020. And we can see that the ex-honorable Health Minister at that time, Dr. Harshvardhan, visited this SHOC center and we were managing the COVID-19 helpline from this premises. This is the photograph of our latest PHEOC center that is based in NCDC. This is a high-end PHEOC center. It has the grid of the available computers, the big screens and high-speed internet facility. From there we can do the Zoom meetings and we can virtually connect with all the states and districts in one go. This is an EOC room that is developed at the Chennai in Tamil Nadu, and this is very often used for managing the health emergencies and the disaster response like the cyclones and severe floods and heavy rainfall situations, and also during the health emergencies and outbreaks. So now coming back, through this slide, we will try to understand the physical characteristics of a PHEOC. what does it requires to become functional, and we should understand, although function is critical, the form must support the PHEOC center. So the PHEOC should ideally offer enough space. It should be large enough to accommodate the multiple functions simultaneously, like the data analysis, coordination, logistics, media response, and sometimes even clinical triage planning area should be there. It must be strategically located, and it should ideally be close to the nodal department or the health authority and easily accessible to the response partners. Internally, the facility should offer the open areas for general coordination. It should also have quiet corners for sensitive communication or data analysis. It should have the closed rooms for briefings, video conferencing, and tactical planning. We should also consider the human comfort factors, especially in the prolonged events, like we should have the sanitary facilities, rest zones, basic food amenities, etc. should be planned before designing any PHEOC structure, and this is very important, especially when the PHEOC is running on a 12-hourly basis or 24/7. And the facility should be resilient and secure, both physically and environmentally. That means it should be earthquake resistant, flood safety should be kept in mind, access should be accessible all the time, and there should be the provision of backup power. Now comes to like how to secure this PHEOC facility. By now, all of you must have understood that PHEOC facility is an expensive resource setup where high value things are present. There is a human resource, so the securing this facility is also essential, and it is not that we think only about the external threats like the disease outbreaks and we neglect the safety of the PHEOC facility. So we should consider the physical security. For this, we need the perimeter protection, the control access. We can have the gate pass or the RFID cards to manage the access, and surveillance. There should be the routine surveillance to keep the unauthorized personnel out. During the high alert situations, these facilities may become the high value targets, and they may simply attract the overwhelming footfall. Even the routine theft, vandalism, or trespassing can disrupt the operations at a critical moment. Then there should be the provisions of environmental and structural safety. Every PHEOC should undergo a hazard and risk assessment. We should ask the questions like, is the building in a flood-prone area? Is it earthquake resistant? Are there enough power backup systems robust enough to support a multi-day operation? I'll give you an example. In Chennai, for instance, the public health control room factored in the cyclone vulnerability, elevating the power banks and server racks to avoid the water damage. Then comes the question of the cyber security. We are handling the lot of data. The data has to be protected. So digital POC, the data is very important, and that means the protection from malware, ransomware, hacking attempts, or even the basic system crashes should be kept in mind, and the system should be designed in a way to address all these things. So information system is the digital backbone of a PHEOC. In the today's response landscape, information is not just support, it is the lifeline of any PHEOC. An effective PHEOC information system must serve three critical purposes. First, it must uphold the data security, privacy, and confidentiality. We are dealing with the sensitive health data. Data can be regarding the individuals, outbreaks, and sometimes even the bio threats. So protecting this data is not just ethical, it is strategic. Second is it must ensure uninterrupted operations. That means redundancy, cloud backups, power failovers, routine health checks on the system. An outbreak does not wait for the server maintenance, so all this should be planned prior to the operationalizing the PHEOC. Third, it must be interoperable. This is very crucial. The PHEOC information system must talk to the other national health platforms like the IDSP network, the IHIP, that is the integrated health information platform. Then we have the lab networks. There should be the provision that the data can be pulled from the lab networks like the VRDL, etc., and even the transportation and logistic dashboard should be there. So WHO provides a framework which outlines the 6 important components of an ideal PHEOC information system. The first one is the resource. So resource, it consists of the human resource, financial resource, and the material inputs. Then the indicators like the performance and the situational metrics that we derive from the data we collect. Data sources like the IDSP data, event alert forms, the S forms, L form, the lab reports, hospital emergency medical records, etc. Then data management tools like data cleaning, validation, and data analysis. The platform, this is the actual software and the dashboard with an interface that we will be using for managing all of this, and the information products like situational reports, alerts, epidemiological curves of the outbreaks, and geographical information system layers. To run a PHEOC effectively, it's not just about collecting data, it's about collecting the right kind of data, organizing it meaningfully, and using it for the timely decision making. So we broadly classify data into the 3 categories, and each category serves as a distinct function in the emergency response. So first is the event specific data, the what and where of the outbreak. This includes the basic parameters like what is happening, how many are affected, where are the cases occurring, who is being affected, how quickly it is spreading, what is the clinical status in the terms of recovery, complications, and deaths. This is our epidemiological and clinical data, and it forms the first layer of our situational report. The second category of the data is the event management data. It answers how we are responding. This focuses on the internal operations of the PHEOC, like the number of the human resource deployed, where are they deployed, the medical or the logistic supplies on hand, the partner organizations working along with us, the progress on the key objectives, financial tracking and expenditure. So this forms our operations dashboard, and it shows whether our strategy is being executed and where are the bottlenecks that are emerging. Then the third group of data is the contextual data. This answers where is this happening and what else is going on. So this includes the geographical and environmental insights, population density mapping of the villages, roads, hospitals, the location of the temporary camps, water points, weather and climate conditions, accessibility of the affected area. Like during a dengue outbreak, knowing the rainfall patterns, the stagnant water sites, and urban slum locations can guide the larval surveillance and fogging efforts. So, what is the EOP, the Emergency Operations Plan? An efficient PHEOC doesn't just spring into action during a crisis, it follows a blueprint. This blueprint is called as the Emergency Operations Plan, or EOP. While some may refer it simply as an emergency response plan, but the more comprehensive term, that is the emergency operation plans, reflects a broader scope that includes not just response but also prevention, protection, mitigation, and recovery. So what is an EOP exactly? So basically it's a document that is developed before an incident ever occurs, and in many ways it defines the DNA of our emergency response system. It answers the critical questions like who does what, when, and how. So there is no duplication or gaps in response. What resources are needed and where will they come from? So it addresses everything from people to logistics, and this avoids last minute scrambling of things. Who is in charge during each phase of emergency? So clear lines of authority are established, and basically this avoids any kind of friction or turf issues during the crisis management. Then what is the formal role of health authorities? So basically they are responsible during all the stages from early warning through to the recovery phase of the outbreak. So basically EOP is a strategic instruction manual. Without it, relying on the memory may lead to the stressful conditions while managing any health emergency. The second concept under the PHEOC is the concept of operations, which is also known as the CONOPS. So now we have understood that EOP is the strategic plan for the emergency readiness, but the next step is to operationalize it. There is when the concept of operations come into the picture, so it can be regarded as a core component of the EOP. And CONOP, it defines not just what needs to be done, but how exactly it will be executed when the emergency hits. So at its core, it outlines the policies and the protocols which needs to be followed. It defines the roles and responsibilities of the key players, like how the teams will interact structurally and functionally during the response. But it goes deeper than that, and it brings order to the action. The CONOPS maps out the various things like the escalation logic. You can see on the right side of the slide, like at what point does a district event becomes a state or the national emergency. Then it defines the strategic, operational, and the tactical layers, who thinks, who directs, and who executes. This clarity is very vital. Then the overall response structure, whether it is follow the incident command system or a unified command or a cluster based response. Then the grading of emergencies, how do we classify the severity, whether it is a routine event, whether it is an alert or a full scale emergency. Then escalating of the response, when should a response shift from the local to a more central level. The organization of the response components, like how the lab teams will coordinate with each other, how the rapid response teams will coordinate with each other. So briefly, the CONOPS can be considered as the bridge between planning and execution. So the emergency operation planning in the context of India, I can say we have two structures that we follow. These are the contingency action plan. So contingency action plan, this is a proactive pre-developed document drafted by the government of India, mainly for natural disasters. And recently we have done it also for the pandemic preparedness. So basically the contingency action plan is updated periodically, and it contains the predefined SOPs, trigger points, and resource mobilization exercises. The purpose is simple. When the disaster strikes, the response should not be delayed due to the planning on the fly. It should enable the immediate rollout of the relief measures, logistics, and coordination mechanisms. The second is the incident action plan, also called as the IAP. It is developed in real time, and it is for a specific operational period during an active emergency. It is much more tactical and time bound. It answers some basic questions like what are the targets and objectives for the next 24 to 48 hours, who is doing what, where, with what resources, what are the communication and the reporting lines. It may be a written document or even the oral instructions during the fast moving events, but it is essential for the coordinated and the focused action. Together, both the things, the contingency action plan and incident action plan, they forms the strategic and tactical layers of the emergency response planning in India. Then we have two more concepts under the EOC. One is the all hazard plan, and other one is an event specific plan. So let's understand both of these things. The all hazards plan, this is the foundational layer of the emergency operational plans. So it outlines the standard incident management structure, decision making processes, coordination mechanisms and resource mobilization protocols that can be applied to any emergency, whether it is a heat wave, a new outbreak or a natural disaster. So basically, this is a basic response skeleton, the basic framework that ensures that you never start from scratch at the time of emergency. Then we have the hazard specific plans. So these are typical for the type of the hazard that we are dealing with. So these are the detailed playbooks which are tailored to the specific threats, like the cholera outbreak or a Nipah virus transmission or a chemical gas leak or a nuclear event. So basically, you can understand they add the muscle and nerves to the response skeleton, and these plans they are built upon the comprehensive risk assessments, and they includes the unique clinical and public health protocols, specialized teams and supplies, specific communication strategies, the media and the mass management, and the risk mitigation measures. These are the three functional levels of the PHEOC. A well-functioning PHEOC is not just about being in on and off state. It operates in a defined progressive modes, which are based on the severity of the disaster or outbreak and depends upon the scale and the urgency of the public health event. So basically, this allows the response to be a measured, very well calibrated, and a resource efficient response. So the first one, the basic level is the watch mode, and this can be considered like the routine monitoring. So this is the default mode or the standby mode. The surveillance data is being routinely monitored. Early warning signals are being assessed. The media scanning is done and the system remains the alert. Like I can give you an example, like under the IDSP, we pick up a slight rise in the cases of the acute diarrheal disease from 2 neighboring blocks. The PHEOC stays in the watch mode. We verify the signals and we await the confirmation from the district. Then second is the alert mode. This is slightly a heightened response above the watch mode. The PHEOC may activate the partial staffing. It can begin contacting the partner agencies. It can start reviewing the relevant response plans and prepare the resources for rapid deployment. Like a confirmed case of Nipah virus in Kerala can lead to the alert mode under the PHEOC response. Then third one is the response mode, which is also called as a full activation. This is when the threat is confirmed and the response system is fully mobilized. The PHEOC shifts to 24/7 operations. The incident command is formally activated. Field teams are deployed. Logistics are tracked in real time, and the public communications become proactive. Like during the second wave of COVID, many states and national PHEOCs they operated in the sustained response mode for the weeks, and they were handling the everything from oxygen logistics to mortality surveillance. And I can say the key here is not just reacting but responding strategically and in proportion to the emergency. This is a brief about the integrated disease surveillance program under which presently the PHEOC under the NCDC is functioning. So basically we have 5 surveillance objectives under the IDSP program. The first one is to detect the early warning signals of the impending outbreaks of selected communicable diseases. At present, we are doing surveillance of approximately 50 plus communicable disease conditions, then initiation of timely and effective public health actions. So basically these actions can be like the basic actions like the verifying the outbreak to the full scale deployment of the rapid response teams. Then the third objective of the IDSP is to create a trained cadre of responders at the district, state and the national levels, and we are supported in this endeavor by the NIDM and the CDC India. Then reducing the mortality and morbidity due to the communicable disease outbreaks. And under this system, we have 3 levels of data collection that we collect to the syndromic surveillance, presumptive surveillance, and lab surveillance. The IHIP is basically the information system or the platform or the dashboard that we are presently utilizing for collecting all the data under the IDSP program. So the key features of IHIP platform is that it is a real-time data reporting system, and the data can also be collected through the mobile apps. It is accessible at all the levels. All the health facilities and the senior level functionaries are given an access into the IHIP system. Then the advanced data modeling and analytical tools are inbuilt in the system. GIS-enabled graphical representation of data is possible. Role and hierarchy-based feedback and alert mechanism provision is there. Geotagging of reporting health facilities, which helps us in generating the heat maps of the disease. Then scope for data integration with other health programs. Right now, the HIP platform is integrated with the 10 other national programs, amongst which the most important are the HMIS system, the ICMR VRDL system, the malaria and the dengue module of vector-borne disease control program. Presently is working through the HIP platform. So basically, going forward through this, the webinar and understanding this EOC is that we should promote the integration of the EOCs and the PHEOC structures at the national, state, and the district level, so that they align with the global best practices. And in this regard, many states and districts have taken a lead. They are going forward with establishing their own PHEOC network, and the technical collaboration is available through the NCDC and CDC-India office. Then develop and regularly update the comprehensive emergency response plans. They should not be lying idle. They should be like refreshed, they should be rewritten, and they should incorporate the multi-hazard risk assessment and scenario-based planning. And in the modern world, with a lot of digital tools and resources available, the GIS mapping, the real-time dashboards, and AI-powered alert systems are there, which can be used to enhance the early warning signals, information flow, and decision-making. And right now, under the IDSP HIP system, we are using the AI-based, the media scanning network that helps us in event-based surveillance. A lot of the health alerts are generated through this system. So there is the scope of leveraging all these, what is available in the modern technology. So basically, this was all that pertains to the EOC, and I again thank you everyone for your keen listening. Over to you, Tanzing.
Thank you, sir. Thank you, sir, for your insightful and engaging presentation of PHEOC. Your clear articulation of key concept, operational frameworks, and field experience added great value and enriched our participants' understanding. We truly appreciate your time, expertise, and continued support to the PHEDM initiative, sir. Thank you, sir. Dear participants, to take a quick poll to this session, to gather your reflection on the first session on PHEOC, please share your responses to help us evaluate and improve future sessions.
आप लोगों के स्क्रीन पे हम अभी भी देख रहे हैं कि पार्टिसिपेंट कुछ रेज कर रहे हैं, जिनको इशू हो पा रहा है वो लोग का स्लाइडो एक्टिव नहीं हो पा रहा है। तो मैं आप लोगों को फिर से 3 चीजें ध्यान से सुनने को कहूंगी कि जिन लोगों ने ऐप के थ्रू या ब्राउजर के थ्रू या मोबाइल के थ्रू ज्वाइन किया है, डिफरेंट प्लेटफॉर्म है, इसलिए स्लाइडो के ऑप्शन डिफरेंट आएंगे। आप एकदम अपने बॉटम साइड पे देखिए, किसी का ऐप ऑप्शन आएगा, आप उस पे क्लिक करेंगे, आपको स्लाइडो दिखेगा, SLIDO। तो आप प्लीज अपना स्लाइडो को एक्टिव कर दीजिए। किसी के आप सेकंड यहाँ पे आप देख सकते हो कर्सर, यहाँ पे जहाँ पे हमने क्रॉस का साइन है और वहाँ पे डायरेक्ट स्लाइडो लिखा होगा, तो आप प्लीज उसे क्लिक करिएगा। और सबसे पहली बात है कि अगर किसी की पार्टिसिपेंट वाली विंडो ऑन है तो आपको ये ऑप्शन नहीं दिखेंगे, तो इसलिए प्लीज आप इस विंडो को क्लोज करिएगा पार्टिसिपेंट वाली को। और जिन लोगों ने मोबाइल के थ्रू ज्वाइन किया है उन लोगों को क्वेश्चन डायरेक्टली पॉपअप हो जाएंगे। अगर कुछ लोगों का इशू होगा, उनके क्वेश्चन डायरेक्टली पॉपअप नहीं होंगे, तो आप काइंडली ये वॉल्यूम के साइड में 3 डॉट्स है, उन पे क्लिक करें। क्लिक करने के बाद एक एडवांस ऑप्शन आएगा, आप उस पे क्लिक करेंगे और सेकंड नंबर जो ऑप्शन होगा स्लाइडो होगा, आप उसे क्लिक करेंगे तो आपको क्वेश्चन दिख जाएंगे। तो चलिए हम अपना पोल स्टार्ट करते हैं इस सेशन के लिए। तो आप लोगों की स्क्रीन पे क्वेश्चन आ गया होगा, व्हाट आर द 2 मेन टाइप्स ऑफ PHEOC फैसिलिटीज? फर्स्ट ऑप्शन इज डेडिकेटेड एंड मल्टीपर्पज फैसिलिटीज, सेकंड इज सेंट्रल एंड रिमोट फैसिलिटीज। अभी तक हमें सिर्फ 13 वोट्स मिली हैं। मैं सभी पार्टिसिपेंट से अनुरोध करूंगी कि वो इसका रिप्लाई दें। नेक्स्ट क्वेश्चन की ओर बढ़ते हैं। नेक्स्ट क्वेश्चन इज विच ऑफ द फॉलोइंग आर द की एलिमेंट ऑफ PHEOC? फर्स्ट ऑप्शन इज स्ट्रक्चर, शेल्टर, supplies. Second option is staff, system, stuff. Third option is sign, symptoms, support, or none of the above. तो 68% हमें आंसर मिला है स्टाफ, सिस्टम एंड स्टफ के लिए, जो कि सही आंसर है। सो मैं थैंक यू वेरी मच फॉर आंसरिंग ऑल द पोल क्वेश्चंस। नाउ ओवर टू यू मिसेस Tenzin.
Thank you, Ram. And thank you for all participants for active participation. Now we move towards the second technical session, which is on activation to action, operationalizing a health emergency operations center. For our next session, I'm pleased to welcome Dr. Sujit Kumar Singh, public health expert and a former NCDC Government of India, and he will present on the operational journey of Health Emergency Operations Center from its activation protocols to the real-time coordination, decision support, and cross-sectoral functionalities during emergencies. Over to you, Dr. Sujit, sir.
Thank you very much, Tenzin, and very good afternoon to all. My regards to ED, NIDM, Rizviji, Director NCDC, Professor Surya Prakashji, Dr. Saurabh Goel, and Dr. Rajat. Apart from that, we have many learned colleagues who have joined as panelists from the state side and from the center side as well. So my regards to all of them. And now just to take forward the presentation with Dr. Saurabh has very elaborately discussed the establishment of HEOC. He focused on the type of data, situational aspects, event-related data, contextual data, operational data, and also touched upon the plans which are relevant as far as HEOC are considered. It may be emergency operation plan, it may be contingency plan, or it may be other aspects as well. He also mentioned that what type of value addition can an HEOC add to the surveillance dynamics which we are currently handling. More than 50 diseases which are outbreak-prone diseases, and some of them have got relevance with regard to going from the outbreak to emergency, and then from emergency to disaster, as we have seen during the recent time of the COVID-19 pandemic. So just I'll take you through the activation to action with regard to operationalizing an HEOC. So when we see the HEOC, which has been termed in many different aspects, like war room, like public health emergency or emergency operations center, as Dr. Saurabh had mentioned in the previous talk, which is focused on the staff systems and operations aspect. So with regard to the preparations, what we see from HEOC, you have to clearly understand that HEOC is not a very, very complicated or complex type of place. I saw one of the comment that in many districts HEOC is not there. But we have to clearly understand the functions which we are envisaging under HEOC are the functions which are very, very critical as far as making our system, surveillance system robust and having a very, very proactive response. So in this, the HEOC concept is basically to assist with regard to the situational awareness, risk assessment, planning and functions, preparations and plans, and also having a capacity building. For this purpose, it is important that we do regular exercises and we have a coordinated response, which includes all activities related to investigation response and going down up to the recovery. There is a physical layout of HEOC, which will be shared with you, and many of you who have already undergone PHEDM trainings, they already know about this structure. So next, please. So in the next aspect, I'll just touch upon some of the initiatives which the Government of India has taken under Pradhan Mantri Ayushman Bharat Health Infrastructure Mission, PMAB. Apart from the many branches of NCDC, 5 Metropolitan Surveillance Unit, 5 regional centers, 20 Metropolitan Surveillance, many other structures have been supported by Government of India. So apart from that, what is important in this particular context is setting up of 15 health emergency operations center in various parts of the country. They will strengthen the central surveillance unit of NCDC and will also have a networking with other HEOCs which are working under disaster management or disaster cell or in many other departments like wildlife, animal husbandry, and so on and so forth, climate change, etc. Next, please. So if we move forward, there are two main aspect activities which can be summarized with regard to the HEOC. One is activation of HEOC and second is the activation of the incident response system, because basic purpose of the HEOC is to have a coordinated intersectorial response. For this, what we require is the data, as Dr. Saurabh has mentioned, and that data needs to be facilitated for rapid analysis and rapid transformation of the information to the relevant stakeholders. There is provision through this HEOC, a virtual interaction between various stakeholders, so that the field activities which are the backbone of a surveillance response system are coordinated or have a very, very robust guidance from the eminent experts of various stakeholders, as per the plan which has already been communicated. Now coming down to the incident response, it's an institutional framework. What we require is an on-site and off-site hurdle-free execution of the planning, operations, logistics, financial and other aspects. There are many systems which are working under EOC, and when we have a networking of EOC, then apart, regardless of the public health emergency or the event or PHEIC, it basically deals with the principles of incident response system. Basically, which focuses on the structured proactive approach, and it also have a strict mechanism for effective containment and robust recovery. So these are basically the principles of IRS, and on this functions the incident response system. Next, please. If we look at the levels of HEOC activation, it ranges from low level of activation where we use minimal of resources, and mostly it is managed by the EOC staff, which is there for limited augmentation. It coordinates the basic response and it also coordinates the reporting functions. Primarily, this is a regular type of activation, which is mostly going on a regular basis, and it does not require much additional resources apart from the dedicated resources of the HEOC. When we come to the medium level activation, it involves little bit more staff. As we have seen during the COVID times, we started with a very, very small control room type of call center, what you can say as a EOC, and then it was scaled up to the full scale type of EOC when the COVID pandemic is spread, and when we had the surges and when we had to interact with numerous stakeholders, not only the surveillance people, laboratory people, genome sequencing people, vaccination people, hospital-related data. So all these stakeholders, they were required to be having the data or having regular coordination, because one set of data gives a action-related trigger to the other section. So when we have these kind of activation, then definitely we are able to manage the situations in a much more better way. Then comes the surge capacity. In many events, when we require a multiple coordination or the extent of spread of the event is beyond our expectation, then you require surge capacity also, you require escalation readiness, and for this, the staff needs to be trained well in advance, and they need to be aware about the roles and responsibilities which they have to undertake. Another important part of this particular activation is that country has to take a call with regard to activation triggers for all levels. There has to be a clearly defined operation plan for where the triggers have been clearly indicated, and this helps timely activation of the HEOC. Next, please. Now coming down to full-scale activation. Full-scale activation, as one of the listener was highlighting, that when we experienced this was done during the time of COVID-19. We had continuous high-scale, highest level activation of the EOC of HEOC, and this was in regular coordination with the state level EOC, whether it may be Gujarat, it may be Maharashtra, it may be Andhra, or many states had got direct linkage with the EOC of the NCDC. And then comes the maximum complexity which is required to be faced during the time of these emergencies, because when you require the data from a particular source, data is for action, and when we have the action as per the national strategy, then the actions are being coordinated in the field. So you have to have a robust mechanism where data input, data analysis, and the actions are done in a very, very coordinated manner and in a timely fashion. And this requires extensive use of national resources, and also at times the full-scale activation also requires international assistance, as we have seen during the time of COVID also, and during the time of many other outbreaks also. We require regular interaction or regular coordination with the international media, like H1N1 PHEOC when it was faced in 2009. Now coming down to multi-stakeholder coordination. The Nipah virus outbreak, which is currently going on in Kerala in 3 districts, Palakkad, Malappuram and Kozhikode. So we had this outbreak in 2018 where we had extensive mortality. But point to highlight here is when you have such during the time of COVID-19, 2018 outbreak, the families from the affected area were displaced in around 18 distant locations. And to monitor these families with regard to the symptoms was a key challenge. And at that point of time, the state level EOC was in direct coordination with the district level EOC, where these families were displaced. And our field level functionaries were regularly monitoring these families for development of sign and symptoms, and then taking samples as per the need. So these all actions were coordinated in a better way when there was a full coordination between the HEOCs or the district level, state level, and also at the level of NCDC, because many other states were also getting regularly coordinating with NCDC so as to get the latest information and what measures they are also required to take at their level, because that was a very, very unusual event in 2019, but current outbreak is being managed in a better way. Next, please. So when we look at the criteria for activation, there are 8 different criteria which are really relevant. Number 1, the capacity of the district or the state where the incident has occurred. Many times this capacity is overwhelmed. So in those situations, we require additional reinforcement of the human resource, and particularly the potential PHEIC. During the time of PHEIC under IHR 2005, we have till now faced more than 6 like Zika outbreak, monkeypox, which was very, very recent. So in these situations, you require activation. I think most of us will remember when the first 3 cases of COVID-19 pandemic occurred in the students which were called back from Wuhan, and their contacts, particularly second case, contacts were more than 257. They went to 18 different states, and in those states they were being monitored for their symptoms during the quarantine period. So the role of central level EOC was very, very critical during that time, because they had to be monitored as per the Ministry of Health guidelines for complete 1 month. So this is the situation, or this is the type of role which a national level EOC plays, and when it gets such a situation, then there has to be proper interaction with the state level EOC. What we require is high level of public awareness regarding that. Additional resources are required. There are some instances where you have cross-border effects also. So monitoring these cross-border spread, it may be outside district, it may be outside the state, or it may be outside the country as well. So all these effects are properly monitored by way of having effective coordination between the two. Now, there are certain areas where the media interest is also high. It may be technically little less hype, but when media hype is there, then we have to satisfy with the facts and figures, and those facts and figures should be very, very relevant and linked to the field level operations as well. So at these points of time, we have the activation which gives us right data at the right time and is able to satisfy most of the needs which are required. Next, please. So now coming down to the authority, mostly in most of the situations when we activate the HEOC at the state level, it's a state surveillance officer or the SSO which gives the proposal and which does a sort of a risk assessment of the situation, that is time, place, person distribution, that what is the risk assessment and how it is going to have an impact on activation. This particular data is given to the principal secretary or to the higher level authority who is competent for activation, and then he takes a decision on the basis of the inputs or the technical inputs which are there. There are certain political reasons also, or there may be some unforeseen situation, or when you are facing with a disease which is unknown type of disease in the beginning. So when the disease is unknown, at that point of time also we require activation. So what is required for the activation process is, number one, conduct a risk assessment. Number two, get the activation criteria fully notified. We have to have a direct instruction from the top level authority. We have to activate, we have to be aware that which activity authority is going to take a decision with regard to this, what is the incident command system, and in exceptional circumstances, there are certain direct level authority instructions also, which trigger the activation process. Next, please. Now, the notification, this is very, very important. When you activate an HEOC, you have to see that what is the level at which it's activated, who has been assigned the responsibility of leading the activation process, and it has to be communicated to the relevant stakeholder, so that every stakeholder is aware that he has to directly get in touch with the HEOC and provide the relevant data to them, and also get the proper instructions with regard to his roles and responsibilities. Next, please. There is a certain checklist. This is very, very helpful, and there are 18 points under this checklist when we want to go for the activation, and this checklist is very, very helpful when we go with that. First is notification. Second is you have to designate incident manager. Then we have to also clearly indicate the various sections like operations section, logistics section, planning section. I think PHEDM training persons are already aware about these sections, and when the IRS exercise is conducted, a real scenario is given to them, and they must be aware that what type of important role these sections play. Then there are positions which are required to be filled so that the EOC functions in a normal well. Apart from the staffing or the HR or the additional support, there has to be an incident action plan which has to be developed and which has to take care about the various activities which are strategically decided. Now coming down to the other surge needs, and surge need is very, very important because when your system gets overwhelmed or when the situation is complex, you need to have additional staff or additional competent staff to man your HEOC. Most important part is that you have to have a periodic briefing of all the staff which is manning the HEOC and the task assigned to the HEOC with regard to incident response system and the stakeholders and what are the roles and responsibilities. If all these points are very, very clearly indicated, then definitely the operationalization or the activation is done in a very, very seamless manner. Other checklist, next please. If we look at the other points of the checklist, they are that the issue the action job chart, the situation report, which has to be regularly prepared and disseminated to the regular stakeholders. It can be an active log is also conducted, how the shift plan can be changed, who can be on the next change. So all these aspects which are a regular form in a roster form are very important. One more thing which I would like to highlight, there has to be a roster of experts from all the multiple stakeholders which are required to take part as per the EOC plan. So when all the stakeholders have a nodal officer, they have the relevant expert, then the expert advice on the basis of the data analytics is available for the field level operation. Then the real role of HEOC gets going. And here the role of partners and private sector, many times we also have to involve the private sector also to provide information, because whenever any event or the emergency or disaster occurs, it is not only the government but also private sectors have to play a very, very proactive role. Next please. Now coming down to HEOC, which is being activated in our country, which is basically at 3 levels. One is grade 1, which is purple. Second is the grade 2, which is orange color. And third is the grade 3, which is colored red. It is 8-hour, 12-hour and 24-hour activation. And we can see that this time can be changed as per the situation, but this is the normal time when we have partial activation, activation of full scale, and activation beyond full scale. So all these activations are being done at the NCDC HEOC or the national level EOC, which is primarily monitoring the surveillance and response from the IH and is linked directly to the IHIP portal. Next, please. Now coming down to most important aspect is when you activate a HEOC, it is also important to realize that this particular HEOC has to be de-escalated also. And that de-escalation has also to be very, very clearly defined and linked with the scope, complexity and severity of the health emergency, because whenever the situation decreases or the escalation, de-escalation is required, you have to clearly assess that how the situation is behaving, whether it's the PHEOC has been declared or over by the WHO DG, or whether your human resource or the surge capacity has been, requirement of the surge capacity is reduced. And similarly, media interest has also died down on the particular event, and the geographical extent of the event is also reduced. So all these things drive our decisions with regard to deactivation. And this has to be based on the risk assessment and periodic review of the level of activation, that how it is really helping us, and then a decision for the de-escalation has to be taken. Next, please. Other aspects of deactivation are, because there has to be authority, the authority which has activated, which has given approval regarding the activation, that authority has to be briefed about the criteria, the data trends from the field are suggesting that the event is on the decline. Second is the issue is no longer a public health threat. Third, it can be that the state is no longer overwhelmed or the stored resources are quite sufficient with regard to managing the event. So all these things are, or the Ministry of Health has taken a call, like Joint Monitoring Group in the Ministry has taken a call that we can deactivate. So all these are the areas where deactivation. Next, please, for the deactivation. Another checklist regarding this particular checklist gives a clear indication that we have to have a proper record of all the appropriate agency, and those agencies should give us regular data, regular situation report, regular message forms and others, so that way we have a record that the activation process has been now deactivated, particularly with regard to the areas where it was coordinating with the multiple agencies, so that the deactivation is done in a very, very scientific and a technical manner. And at a later date, when somebody asks, we can present that particular report and give a scientific evidence with regard to deactivation. Next, please. So now this is just an information flow which has been as per the Ministry of Health, Government of India guidelines. Cabinet Secretary under the Prime Minister is the key authority, and there are under him, if we divide it into two, there is a central control room, there is an under the Ministry of Home Affairs, which is linked with the disaster NDMA, which is the key authority, and from public health aspect, and National Center for Disease Control has got the EOC. This is linked with the state EOC, and similarly, the NDMA has got the state disaster management authority, district disaster management authority, and they have a dedicated plans under their control, and these two have a responsibility with regard to the public health management of the emergencies and disasters. Next, please. So, as a way forward, there are certain these 4 points which can be highlighted. Establish a dedicated team with clearly defined roles. Conduct regular training, simulation exercise, tabletop exercise. This particular thing strengthens the coordination mechanism, particularly the health, disaster sector, and the other sectors. There are many sectors which are specific event. If you are dealing with the event like Nipah virus, you have to have coordination with the wildlife sector. Similarly, if you have the event which is related to climate, then you have to have the experts from the climate thing. The integrator, there is a need that HEOC training has to be integrated into the public health emergency and disaster management, because many times our sectors are involved in a more a reactive manner. We have to have a proactive involvement or integration between the two sectors and other sectors as well, as per the need of the event or as per the need of the emergency. So I'll stop here, and I will request participants that if they are interested, they can go for further reading, which is there in that line. I think the presentation will be shared with you, and thank you very much for your patient listening.
Thank you, sir, for your insightful presentation on operationalizing the health emergency operations centers in India and your experience in managing activations and deactivation, especially during the COVID-19. Provide valuable practical lessons, and we truly appreciate your clarity, leadership, and the structure approach you share with us today. Next, we want to invite everyone to participate in a second quick poll to capture your feedback from this session. At the bottom of the screen on the right side, go to app and then click on the Slido. There is active session. There you will see the poll questions with some responses.
आप लोग की स्क्रीन पे क्वेश्चन आ गया है. HEOC stand for Health and Emergency Observation Cell, Health Emergency Operation Center. Third option is Hospital Emergency Operation Command. I would request all the participants to participate in the poll questions. We have received only 20 votes. Most of the participants answer correctly. The answer is Health Emergency Operation Center, which stands for HEOC. So thank you very much for participating in the poll session. Now moving over to you, Ms. Stella.
Thank you, ma'am. Now we come to the question and answer session. I would like to request participants to raise your question or queries in the chat box, and we encourage you to share the queries and reflection from your local context as well. There is a space for shared learning. We have received one question for Saurabh sir, and the question is from Mr. Alok, stating that in disaster EOC, we use GIS extensively. How does the integration of digital tools like GIS mapping and real-time dashboards enhance the operational effectiveness of a PHEOC during the public health emergency?
Thank you, Tanzing, for asking this question. And I think this question is very important. My answer should give an insight like how the GIS mapping and the dashboards can be useful for fortifying the PHEOC response. So basically the GIS mapping, it provides a geospatial representation of the outbreak locations, the health facility coverage, the case clusters, population density, and affected areas. So they helps us to visualize the spread and trend of the disease in real time, and it allows the PHEOC to prioritize the high risk zones. It also supports the hotspot identification and rapid decision making regarding the containment and resource allocation. Now coming on to the dashboards. So basically these dashboards, they are designed in such a way that they consolidate data from the multiple sources. The sources are like the surveillance systems, the lab data, the health facility, the location, the logistics and contact tracing, and they provide the single operational window to overview all the key indicators like the case counts, the bed occupancy, the testing rates, the case positivity rate, case fatality rate, the vaccination status, etc. So they enables a very quick situational assessment. They allows for the real-time tracking of the key performance indicators and developing the early warning signals. So I hope this answers your question.
Thank you, sir. Thank you for answering the question. I hope, Mr. Alokji, you received the response from the questions you have raised. For next question, we have a question for Dr. Sujit, sir, from Mr. Bharat Kumar, stating that, can you share a time when your team had to activate an PHEOC at national level? What were the key challenges and the lessons learned?
Thank you, Mr. Bharat, for your question. And we have activated national when I was at NCDC. NCDC EOC has been activated many times. I remember distinctly that it was activated during Nipah virus. Before that, Ebola threat was there. And then we had activated during the time of COVID-19 pandemic as well. Three different situations. Ebola, it was the situation from point of entry where the monitoring was primarily linked with the point of entry to the surveillance network, which was in the in-country surveillance. You have contacts, you have exposures, then you have to track it in the community. So from the point of entry to this. Second was Nipah virus, which happened inside the country, and there the surveillance network has to be coordinated with the NIV Pune or the testing strategies or the community level strategy, because a lot of IEC activities were coordinated during that time. Contact tracing, which was done for the exposed or the potentially exposed, which were anticipated to be exposed during the cases which were initially there. And so at that point of time, the challenge was to contain the infection between the two districts which are affected during 2019. Then coming down to the COVID-19, it was really very, very challenging when we did not have vaccine, when we did not have any drug. In the initial part, contact tracing was very much assisted by this. And you must be remembering that we had containment zone, when we had identified a particular case, how the contacts were clearly coordinated by the field team and the data and the testing strategy was linked with that. When we find the case, then the testing team has to be clearly guided with that particular area, where many times we had to go with the saturation testing. That whole area need to be tested for identifying the potentially exposed persons or the infected persons from the exposed person. That was one. Next came the search time, when you have to link it with the variants. So INSAPOG was created, then INSAPOG linking or genome sequencing was linked with the public. And then we had many measures which were non-pharmaceutical, which were driving from the community, or the law and order was pulled in. Many means finally from the whole of Ministry of Health approach, it became the whole of government approach. So that was basically coordinated by the EOC. And when we look at the final phase, when vaccine came, when hospitalization data has to be linked with the variant, which vaccine variant is giving us more challenging time. So these were the challenges you have to coordinate with various structures. Like hospital data getting was a challenge. We had challenge with regard to getting all the genome sequencing labs giving data at the right time and then tracking that particular variant data into the community. That was a challenge. During COVID time, getting wildlife sector properly involved was a challenge. So there are challenges. We have come a long way, and I think we have a very, very efficient team at IDSP which is driving this further, and we have to take down from national level to the state level to the regional, other district level as well. I have seen one question that at district level we don't have, but if you look at the journey of IDSP of 20 years, which was recently highlighted, and there is a very good film on that. At NCDC also 20-25 years back, we did not have all these things. Now we have moved from that particular stage to this stage. So it should not be felt that you need a very, very sophisticated structure to make a beginning. My suggestion would be make a beginning, learn the things that you need the data, you need the data analytics, you need the coordination between various sectors. If you can do all this to a control, I think that will be a great step forward. And when in due course of time, we will have equipments at every place. So I'll stop here. Thank you very much for your question.
Thank you, sir, for answering the question. I hope Mr. Bharat ji आपको अपना response मिल गए होंगे. And I want to thank you all the participants for active participation. Due to time constraint, we are not able to answer each and every question. So we have picked selective questions to answer by the speaker. And for your information, our panelists answer your query in the chat box and kindly go through it. Now, I would like to request Dr. Rajat Khat, Public Health Specialist from US CDC India, to deliver the closing remarks for today's session. Over to you, sir.
Yeah, thank you, Stenzing. So I would like to firstly thank the patrons as well as the course chairs from NCDC, NIDM as well as CDC India for providing their guidance for this webinar series. I would like to thank all the participants. This webinar series has been conceptualized. This is actually an idea of the participants of these PHEDM Tier 3 trainings. They've asked us to, they wanted continued learning. That's why this webinar series has been conceptualized, and this is the third webinar. In every webinar, they participate in large numbers. I will also like to tell the participants that this webinar series, this is also live in NIDM YouTube channel. So you can go to the YouTube channel and you can access those webinars, like first and second webinars, which have already been conducted. The next webinar will be on 22nd of August. So my request to all the participants that they should also connect to that webinar on 22nd August from 3:30 p.m. to 4:30 p.m. And my thanks to everyone in the organizing team for making this event successful. Thank you. Over to Stenzing.
Thank you, sir. The session comes to the end, and I would like to acknowledge the support of Shri Safiyasan Resvi, IPS, Executive Director, NIDM, Professor Dr. Ranjan Das, Director of NCDC, Country Director, CDC India, Professor Surya Prakash, Head GMR, DCBRN, and Industrial and Cyber DRR, NIDM, Dr. Himanshu Chauhan, Dr. JD, and HOD, IDSP, NCDC, Dr. Runa Hatigogle, Associate Director for Science and Program CDC India. And I would like to extend heart thankful to our esteemed speaker, Dr. Saurabh Goyal and Dr. Sujit Singh for their experts' insight in the real world perspectives. I also thank to our collaborative partners at NCDC, CDC India, and my colleagues at NIDM for their guidance and support in conceptualizing this monthly learning initiative. And a special thanks to all participants for your time and thoughtful engagement. And the next webinar in the series will take place on August 22nd, 2025. And we look forward to your active participation in the upcoming session. Until then, stay safe and continue strengthening your role in public health emergencies and disaster management. And thank you once again and have a wonderful evening. Thank you and Jai Hind. We have leave a feedback from your side in chat box. Kindly fill the feedback form and response it so we can make it. Thank you. We have shared the link in the chat box. Kindly fill it and respond it. Thank you.